Hi. Thank you for inviting us to be here. It's been a few years since I've spoken, pre-pandemic. Last time was about SUDEP and death and epilepsy. So I'm happy to be here to speak about a less ominous topic. I'm Dr. Harris, and Dr. Deng and I are going to be talking about accessing appropriate epilepsy care and what that means. I'll be speaking from the experience or the perspective of an adult epileptologist at a comprehensive epilepsy center at the University of Michigan. And so I'll start by describing what is an epileptologist. Well, I am an epileptologist, so I'll tell you a little bit about my story and my training. I grew up in Florida, a beach bum and a science and math nerd, and tried to rebel against my familial profession of medicine by training in engineering. And I studied biomaterial engineering at University of Florida. I think like many people who go into medicine, I was allured by the chance to treat and improve people's lives more directly, which is what medicine provides. So I went to medical school, and in medical school you're exposed to all different branches of medicine, but it was the brain and understanding how the brain worked and how it becomes dysfunctional that really interested me. So I went and studied in Philadelphia for neurology. And neurology is a residency program after medical school, is a year of internal medicine. Then you study for 3 years in neurology, learning all about the different neurological disorders. And so neurologists get variable exposure to epilepsy depending on the program that they study at. But every neurologist takes care of epilepsy, and regardless of what subspecialty they go into later, whether it's general neurology or something else, all neurologists at some point in their careers take care of people with epilepsy. I was lucky to have great epileptologist mentors who directed me in that pursuit and gave me the opportunity to care for people with epilepsy during my residency. And that's really what drove me to want to study it more, was working with patients who were dealing with this diagnosis, this disorder, and working with their families. So I went off and did some advanced training in epilepsy, which is what defines an epileptologist. That could be 1 or 2 years for people. For me, I did 2 years, 1 year of neurophysiology, where you study how to read an EEG, you study other elements of neurophysiology, with some also taking care of epilepsy patients. And then another year for more advanced epilepsy care, where we learn how to work patients up who are really refractory to epilepsy for epilepsy surgery or for other interventions. And then in 2017, I came to Michigan to work as an epileptologist. And what drew me to Michigan, I don't have family here. I have no other connections to Michigan. It's cold. I'm from Florida. But what drew me was the program offered the entire array of diagnostic and therapeutic options that I thought I could use to treat my patients, what I was used to in my training, to deliver the highest level of care. It's a comprehensive epilepsy center, and what does that really mean, a comprehensive epilepsy center? Well, there's actually an accrediting body, the National Association of Epilepsy Centers, and they determined through a structure of provided services and number of patients seen what centers are actually epilepsy centers. And if you go to their website, anyone can go. You could plug in your zip code or the state you're in, and you can see all the surrounding epilepsy centers. So if I zoom in to Ann Arbor, you'll see University of Michigan, both the Adult Comprehensive Epilepsy Center and the Pediatric Center at Mott. And if you zoom out a little bit, you'll see all the regional centers around in southern Michigan, because there aren't any in northern Michigan, but also in the Ohio area. And they will classify levels of epilepsy care, really level 3 and 4 being your epilepsy centers. Level 1 is the epilepsy care you'd get at the emergency room or from your primary care physician. Level 2 care would be something you might get from a neurologist. Like I said, all neurologists take care of people with epilepsy. And then it's levels 3 or 4 where you're under the care of somebody with that more advanced specialized training in epilepsy. The differences between level 3 and level 4 are relatively subtle, but at a level 3 center, you'd get almost all of the care you'd normally receive for epilepsy, including non-invasive diagnostic studies. They may even perform some relatively straightforward epilepsy surgeries and provide vagal nerve stimulators. Whereas at a comprehensive epilepsy center, it's just greater. There's the entire suite of diagnostic studies we can do, including invasive intracranial EEG monitoring, as well as other therapeutic options for epilepsy. But does everyone need to be seen by an epileptologist? At least on the adult side, maybe that's not true, right? If you have epilepsy and your epilepsy is well controlled, you're tolerating your medications okay, then you don't necessarily need to see an epileptologist. But if that's not the case, say if you've been seeing a neurologist, you've had a diagnosis of epilepsy and your seizures are uncontrolled, and it's been 12 months, you've been working with your neurologist to get that under control, still not under control, then maybe you should see an epileptologist. And there might be other reasons to see an epileptologist too. We work very closely with local neurologists in joint treatment often. So just because you go to an epileptologist at an epilepsy center doesn't mean you're abandoning your local neurologist necessarily. And it's true that patients with refractory epilepsy are under-referred to epilepsy centers, and this could be for a variety of reasons, but we know that over the last 3 decades, there's been dozens of new anti-seizure medications to come out to the market, and this has been a boon. These medications are better tolerated, they have less interactions, but we really haven't made a big dent in the percentage of people with epilepsy with refractory epilepsy. It's still about 1/3 of people with epilepsy, or about 3 in 10. And so if that's the case, then why is it that fewer than 1% of these people with refractory epilepsy are being sent to epilepsy centers? And like I said, it's probably a multitude of reasons. Maybe one is a misconception that these epilepsy centers are really just for people who are considering surgery. And I don't think that's the case. Certainly if a patient is a surgical candidate, which is anyone potentially who has tried 2 anti-seizure medications at good therapeutic doses but still having refractory disabling seizures, should probably be worked up for epilepsy surgery to see if they're a candidate. But there may be a host of reasons why patients should come. Anyone with refractoriness should probably come, and we'll talk about that in a second. There may be insurance barriers, right? So people changing institutions, changing doctors, might find that their insurances don't like that very much. However, at most epilepsy centers, there are teams that can work with you to find affordable ways for you to seek this advanced care. So it should never be an absolute barrier, although it can make things difficult. And of course, there are physical access barriers. Geographical, I mentioned there really aren't any epilepsy centers in northern Michigan, so that's a barrier for people seeing epileptologists. There's sort of been a boon in the pandemic age that we've advanced our virtual medicine, and that's really allowed us to increase access to care, particularly for people in more rural areas. However, in rural areas, people might not have great Wi-Fi access or internet access, and that in and of itself can also be a barrier to care. Or there may be devices that we implant that require regular physical interaction that make living in, say, the UP difficult, not impossible. I have patients who fly down from the UP every few months so that we can see them in person. And so it is overcomable, but it makes things difficult. And you may be wondering, why does level of care even matter? And this was a study that came out a few years ago now in JAMA Neurology. This was a Canadian cohort, and it was a really good study. They looked at tens of thousands of patients, and they accounted for age, sex, types of epilepsy, socioeconomic backgrounds, and other comorbidities. And what they determined was that if you look at that top gray line, that is patients who were unexposed, people with epilepsy who were unexposed to neurologist care. The y-axis is risk of mortality, so the higher you are on that graph, the higher your risk of mortality over many years. And the middle line is people exposed to a neurologist, and the bottom line is those who were exposed to a comprehensive epilepsy program. So you can see that increasing levels of neurological care, particularly specific to epilepsy, seems to over time reduce risk of death. And so it is not a trivial matter that appropriate care should be sought. So if you go to a comprehensive epilepsy program like the University of Michigan, what kind of extra services do they provide? And I don't want to go too much into this because we're going to be hearing about surgical evaluations, but just to briefly comment, there are a host of non-invasive procedures that we will do to work up a person's epilepsy. And so those include coming into our epilepsy monitoring unit. This requires, a team of experts, including our technologists, and having a good technologist team is really so important to a good EMU evaluation. We have neuropsychologists who specialize in performing tests and analyzing those tests in people with epilepsy. And that's an important part of any surgical workup for epilepsy. We do other types of specialized quasi-non-invasive studies like WADA testing, where we put half of the brain to sleep with a brief anesthetic and test for language and memory. And this sort of replicates what it's like to have a surgery without actually having to undergo the surgery, and a very important part of understanding somebody's epilepsy before they undergo a surgery. And then things that we have at University of Michigan, which I didn't have at other great epilepsy institutes, are speech-language pathologists who are specialized in epilepsy care, who can do evaluations that complement the neuropsych testing, and a social worker who is also specialized in caring for people with epilepsy, who understands a lot of the different programs around the state, many of them through the Epilepsy Foundation of Michigan, and can share that with patients and give resources, and also work in the evaluation to make sure that patients have the psychological and the social support to undergo something like an epilepsy surgery. And then other types of non-invasive evaluations are the imaging evaluations we do. And this is a type of technology that changes rapidly, and staying on top of that and having expertise in that is really important. So at your basic level, having really high resolution, good MRIs done to look for even subtle lesions that could cause a person's epilepsy are important. And then also having the quantitative algorithms that can identify cortex and then the hippocampus and other areas of the brain to look for subtle asymmetries from the left and the right side can really be important for identifying a person's epileptogenic focus. We also would do a PET scan. This is a scan that looks at the brain and its metabolism of sugar, because areas that are involved in generating seizures don't metabolize sugar well, even in between seizures. And then we might do something like a SPECT scan. Again, this is something I didn't train on, more advanced imaging techniques where we'll inject a technologist will sit at the bedside during an EMU evaluation with a radio tracer, and looking at the EEG, interacting with the patient, and as soon as they start to have a seizure, we'll inject the radio tracer, and that follows the blood flow. And that can, as you can see, at times pinpoint a location for somebody's epilepsy. And in this particular case of the imaging I'm showing was invaluable and to understanding where her seizures came from, and eventually leading to a surgery. At that point, when you've undergone a full non-invasive evaluation, then it takes we discuss a case at a surgical conference. And at many institutions, it's called the Epilepsy Surgical Conference. At the University of Michigan, we call it Refractory Epilepsy Conference, because sometimes the result of that conversation is not we're recommending surgery. It's recommendation of something else. Maybe it's genetic testing. Maybe it's a diet, like Dr. Ding will talk about. But oftentimes it is surgery, and to understand the location of the epileptogenic focus better, we often will do invasive EEG. And that could be with more traditional methods like grids and strips. Now this is where we take the skull off and we lay a grid of electrodes on the surface of the brain. This is really nice. It gives us good spatial resolution of the electrical signals in the brain. And it also allows us to do mapping, which can help us understand eloquent areas of the brain, such as areas involved in motor movements and sensation, as well as language areas. And so if the area where seizures are coming from are near those really important areas for function, we might need to know that through mapping. And then there are more modern forms of intracranial EEG monitoring, and this is stereo EEG, which we do. You'll see that the patient in the bottom right corner there has these sort of electrodes sort of sticking out of his head, and so instead of having electrodes on the surface of the brain, we will stick electrodes through the skull into the deeper areas of the brain, and we do this with the assistance of a robotic arm in the OR, which allows for pretty quick OR times and less morbidity to the patient. So this is a lot better tolerated because we're not taking the skull off, and it's not a big surgery like that. And then afterwards, you might end up with a scheme like this, where you have electrodes coming through both the superficial parts of the brain, but also sampling deeper areas of the brain at the same time. And that's really important to understanding not only where seizures start, but how they propagate and what various areas of the brain might be involved. And it really is the only way to sample from certain deep regions of the brain. And once we've figured out where your seizures are coming from, and we say, all right, this is a reasonable place for a surgery, it'd be relatively safe surgery, and we could do this without causing too much disability, there are maybe different types of therapies available. And so at a comprehensive epilepsy center, all of those therapies should be available. One would be a less invasive type of procedure called LIT, or laser interstitial thermal ablation, and this is something we do at the University of Michigan, where a probe is sent to the location, and the tip of the probe heats up and actually ablates that area of damaged epileptogenic tissue. And so this has a little bit better recovery periods because we're not taking the skull off, and we don't have the morbidity of doing a more open resection. And so maybe we can save areas of the brain that we wouldn't have to otherwise surgerize. But that's not always an option, and that has its pluses and minuses. So open resection is still the mainstay of surgical treatment. And this is where we take the skull off, and the surgeon goes in, finds that area of the brain we've identified through all of our methods before, and then takes it out. And we can also do this in the OR, mapping of the brain, both for motor and sensory modalities, but also with language modalities, and having the expertise, having a neurophysiologist there working with the surgeon, working with our speech pathologist who does the language mapping in the OR with us is an important part of having good, safe epilepsy care. But in addition to these resective and more definitive ablative types of therapies, there's now a whole host of neuromodulation devices. The one that's been around the longest, that many of you are probably familiar with, is vagal nerve stimulation. This was approved in '97 by the FDA for the treatment of focal epilepsy. And in this device, you can see that there's the battery generator that goes just under the fat tissue layer in the chest, and is attached to a wire that then connects to the vagus nerve in the neck. So this is not a brain surgery, but that vagus nerve, is important to increasing inhibition in the brain and reducing that excitation that leads to seizures in people with epilepsy. And more recently on the market, we have two devices, the responsive neurostimulator and deep brain stimulator. The responsive neurostimulator has been approved since 2014 for focal epilepsy. And in this device, it's a closed loop system where we place an electrode or a strip or both at the area of the seizure, and a little computer is attached to the inside of to the skull, sort of buried into the skull. And we train that computer with algorithms over time to recognize seizures and then provide stimulation in response to those seizures. The deep brain stimulation, which we've been using for many, many years for things like Parkinson's disease and tremors, was approved in 2018 for the treatment of focal epilepsy. And this device is an open loop system where the electrodes are placed into the anterior nucleus of the thalamus, and sort of like the VNS, goes on and off over the course of the day. And all of these therapies have their pluses and minuses, and that's something we discuss with patients after we've discussed their cases at our surgical conferences. But like I said, there are other reasons you might want to come to an epileptologist, and most epileptologists, or many epileptologists, are at these epilepsy centers. So anyone with medical refractoriness, I think, should be seen by an epileptologist. Epileptologists have the skill set and as an epileptologist, all I see all day are people with either epilepsy or spells that they think are seizures. And so recognizing pseudo-refractoriness, where medications have not been optimized correctly or are interacting with each other, is a really important part of what I do on a day-to-day basis. Recognizing non-epileptic spells, so people with epilepsy can have spells that could look like seizures but aren't seizures for a variety of reasons. People could just have non-epileptic spells that somebody thought were epilepsy, and they've been treated as epilepsy, and they're going to the OR or the ER every time they have a spell and being treated as if they have epilepsy, and that can be dangerous. Or people with epilepsy can have spells that people don't think are seizures because they look a little funny, and having that expertise can help us recognize, oh no, that's just an atypical seizure. You may have specific questions related to your epilepsy care. So for example, managing certain activities with your epilepsy, having an expert weigh in on that can be really helpful. Maybe you want to switch your anti-seizure medication. So you're having side effects to the medication, you want an alternative, or you're starting a new medication and it interacts with the medication you're on now and you want to navigate that. That's an important reason to see an epileptologist. Or maybe you've been seizure-free for years and you're ready to try coming off of your anti-seizure medications, and you want to discuss what the risk of that is and how to do that in a safe way. Seeing an epileptologist is an important part of that. And then for women with epilepsy, pregnancy and pregnancy planning are reasons to see an epileptologist. So all pregnancies in women with epilepsy are considered high-risk pregnancies. Both the anti-seizure medications we use and seizures themselves can be dangerous during a pregnancy and have risks. And so understanding those risks and understanding how to mitigate those risks, and then also following seizure levels during pregnancy is something you want to do in conjunction with an epileptologist. But I think the best resource you have at a comprehensive epilepsy center is the talent pool, the expertise that comes with that, having a host of people who are dedicated to taking care of people with epilepsy. So at the University of Michigan, we have our neuroradiologist, who is not just neuroradiologist, but really specialized in epilepsy neuroradiology, a neuropsychologist, same thing, our speech pathologist, and our social worker. And these are, like I said, speech pathologists and social workers specialized in epilepsy are things that you really would only get at an epilepsy center. And then we have our neurosurgeons who are dedicated to epilepsy. So Dr. Levin, who does all of our deep brain stimulation surgeries, as well as our laser interstitial thermal ablations. Dr. Oren Sager, who's the director of adult epilepsy surgery, who does our intracranial EEG operations, as well as our resections and our responsive neurostimulations. And then his excellent nurse, Donna, who sees all those patients to make sure that they're appropriate for surgery and then follows up with them. And then, of course, our cadre of adult epileptologists who combine their brain power to help me treat my patients with the best care. And not listed on here, of course, are the technologists who I mentioned, who are indispensable, and having high-quality technologists can really, and I can think of many examples in which their care has led to a diagnosis or led to a change in treatment for patients. And so with that, I will hand things off to Dr. Dang, but thank you for your attention this morning, and I look forward to talking to many of you later.
Thank you, everybody, for your attention this morning, and thanks, Dr. Harris, for the great presentation. I was just telling him, I should say, well, just listen to what Dr. Harris said, because what do I have to add to this? I'm going to try to focus a little bit more on the pediatric side of appropriate epilepsy care. So I'm Louis Dang. I'm one of the pediatric epileptologists at Michigan Medicine. And I think just to start off with, what is appropriate care? And that implies that there's also inappropriate care out there. And I think just to recognize that this is an important health problem, and there is a lot of distrust in the medical system or with the medical system, and I want to recognize that. So, and this affects us locally. So there was a Michigan doctor that was accused of misdiagnosing epilepsy in more than 200 children recently in the last couple of years, and he gave up his license. So to start with, what is appropriate? I think you can think about that in a few different ways. First is the expertise that you're getting. And this is my viewpoint, and I think really what is appropriate is what our patients and families tell us they need. That's the bottom line. What do our patients and families need? That's what is appropriate. But from my perspective, there can be a spectrum, right? There's the worst possible care where you have misdiagnosis, unnecessary testing, unnecessary medications. There might be what you might call inappropriate, like a pediatrician without any neurology training managing anti-seizure medications. Now, that said, in some places around the country, and especially around the world, that's just necessary because there aren't pediatric neurologists around or neurologists around. Appropriate care might be childhood absence epilepsy, treated by a pediatric neurologist that's not an epileptologist. And I think this is one little distinction between pediatric care and adult epilepsy care. In pediatric neurology, epilepsy is one of the bread and butter things for pediatric neurology. I think of pediatric neurology as seeing often headache, epilepsy, and developmental delay. So residents that train in pediatric neurology have a lot of exposure to pediatric neurology or to epilepsy care. Versus in adult neurology, I think some of the bread and butter is more like stroke, which we don't see as much of on the pediatric side. So what is ideal expertise? You would just consider it the care from, quote, the best comprehensive epilepsy center in the world. So access is also an important aspect of appropriate care. Worst would be if your center is completely unavailable to you by phone and you can't schedule an appointment at all. And inappropriate might be you can't really talk to your care team between appointments. I think it's a necessary thing to be able to contact your team between appointments. Appropriate would be you can schedule appointments, talk to the office and nursing staff between appointments, and ideal, which is, again, probably unrealistic, is immediate 24 access to your medical specialists, meaning your physician, I guess. You should have immediate 24/7 access to somebody in the office, I think. This is also a spectrum and also relative because we have times when there's decreased access. For example, during COVID, we had decreased access, and that led to a lot of problems with epilepsy care. Right now, on the pediatric side, we have a huge surge in RSV, respiratory syncytial virus, across the country, and it's affecting Michigan as well. And that's making it hard for us to bring in patients on an elective basis to get epilepsy evaluations because our hospital is so full. So there are times when some of the access isn't ideal for external circumstances too. And then lastly, communication. Worse would be incorrect communication. Your doctor's telling you the wrong thing. Inappropriate might be delayed communication. They're not getting back to you in a timely way. Appropriate would be they communicate with you on time, and ideal would be coordinated, instantaneous, multidisciplinary communication among all of your care providers and all of your care teams. Again, probably unrealistic in a lot of ways, but we can always hope, and this is always the dream that we can try to shoot for. We talked about the NAEC coordinating centers or epilepsy centers and the certifications for that. Just remember that physicians also have certifications and board specialties. So under the American Board of Psychiatry and Neurology, the ABPN, which is the governing board that generally certifies neurologists, you can get certification in neurology, and then you can also have a special qualification in child neurology, and that's what would make you a pediatric neurologist. And a lot of children do get care, especially teenagers, from neurologists that don't have special qualification in child neurology, and that can be okay too. In addition, you can get board certified in epilepsy or clinical neurophysiology, and that's what you might consider an epileptologist. And if you have all of that, then you're a pediatric epileptologist. So I'm going to kind of skip this because David covered that. So when should I see a pediatric epileptologist? Probably once around the time of initial epilepsy diagnosis, but again, not always necessary, meaning, again, a lot of pediatric neurologists are very comfortable with epilepsy care, and if it's a situation where the epilepsy is relatively straightforward, you may not necessarily need an epileptologist right at the beginning. But if the seizures aren't controlled by the general neurologist for 12 months, and that's flexible, meaning if there's a ton of seizures and it's only going on for a month or two, then you might still want to see an epileptologist. With refractory epilepsy, and by that we generally mean 2 or more appropriately chosen or dosed medications that don't work. And then if you want to consider epilepsy surgery or other non-medication therapies like the ketogenic diet, that's probably the appropriate time to see a pediatric epileptologist and go to a level 4 epilepsy center. So the big question is always, well, what if I can't get in to see a pediatric epileptologist? Because access is a big issue, and there are only so many pediatric epileptologists in our state, in our country. Sometimes we don't always realize the urgency of the situation, so have your primary care doctor or your general neurologist communicate directly with the pediatric epileptologist, and maybe they can at least get some suggestions over the phone or via email or whatever before you're able to actually get in to see the pediatric epileptologist. You can call our office to see if there's a wait list or if there's cancellations to try to get in. You can request to see, instead of a particular individual provider, try to see the first available epileptologist or an advanced practice provider, so a physician's assistant or nurse practitioner that work closely with the epileptologist. Honestly, our nurse practitioners are often much more creative and good with epilepsy care than I am, because they see patients every single day, day in and day out, and I'm mostly a researcher. So you can also see a resident or epilepsy fellow who's supervised by an epileptologist. So maybe you're going into a clinic where you're seeing the pediatric neurology resident who's then staffed by an epileptologist or one of our epilepsy fellows. So we have an active epilepsy fellowship program, training program at University of Michigan, and you can see them as well. So when should you get a second opinion or consider switching? So just to take a step back, when we get second opinions at University of Michigan, we often think to ourselves, okay, is this someone that wants just a second opinion and they want to go back to their primary neurologist, which is totally fine, or do they want to switch care to us, which is, again, totally fine. So just keep in mind when you go see a second opinion, and you don't need to decide that right away, but at some point you'll want to figure out, okay, do I want to actually switch my care, or do I just want to get a second opinion to make sure everything else is on track? So it's not just if you're dissatisfied with your care that you want to get a second opinion. It's, again, if you are considered to have refractory epilepsy or considering epilepsy surgery. If you want to consolidate your care within a medical system, so a lot of our children have complex needs and multiple subspecialists following them, and sometimes it's easier to have all of that care within one system for communication purposes mainly. Or if you want to have a local neurologist follow you, which can be more convenient, and then have a subspecialist farther away, that can be coordinated too. And we can kind of work with a local neurologist to help with the epilepsy care. What if I'm too far away from an epilepsy center? Again, you can work with your local neurologist. We talked about telemedicine. And also with certain insurances, with Medicaid, HMO, you can get help with transportation and lodging. So that shouldn't be a complete barrier to getting care at a subspecialty center. How about with no or limited insurance? What are my options in pediatric care? You can contact the Michigan Department of Health and Human Services and apply for MyBridges support to see if you're qualified for Medicaid. You can also contact, a lot of institutions have a patient financial counselor, and that's what we call it at Michigan Medicine, but it might be called something different elsewhere. And for children, there's the Children's Special Healthcare Program, which is a very important supplemental insurance program for specific diagnoses, including epilepsy. And how about other insurance barriers? It's important to understand your insurance and which hospital provider is considered in-network. Again, enrolling in children's special health care, making sure your physician associates the correct diagnosis with the treatment plan and whatever test they're ordering, because if that diagnosis isn't there, then sometimes the insurance company does not cover the ordered tests or medications. Sometimes you need a prior authorization, and hopefully your physician's office has folks that can help with that prior authorization with the insurance company. Make sure you communicate with your medical team when concerns about insurance or other questions arise. And we all deal with insurance companies denying claims, and physicians can actually do what we call a peer-to-peer. The insurance company just talks to us directly, and we have to explain why this is the appropriate thing. For example, a few months ago, insurance company denied a patient I had been following because we had wanted to start them on the ketogenic diet, and they said, well, that's not allowed because it's not a defined treatment for epilepsy. And we're like, wait, hold on a second. There's a whole host of evidence, there's all these papers, and then the physician on the other side that works for the insurance company was like, oh, okay, yeah, I get it now. I didn't realize that, thanks for educating me. So then they approved that method of care. And finally, voting. Being an advocate with state government is really important to make sure that people with disabilities have their needs covered. All right. So at each visit, what should your provider do? They should ask you about your seizures, the types of seizures you have, what the frequency of your seizures are, what they look like, when's the last seizure you had. And if you're still having seizures, there should at least be a discussion about whether there should be a change in treatment, whether that's increasing one of the doses, switching to another medication, or adding another medication, epilepsy surgery, dietary therapy. And if you don't change, then discuss why a change isn't being done and why it's not needed. Ask about medication side effects. They should see if you're having any problems with your medications. Review your diagnosis. So when you walk out of that visit, you should know the diagnosis and what the cause of epilepsy is. Of course, a lot of cases we don't know the exact cause. Discussing seizure safety, discussing psychiatric and developmental comorbidities, and discussing seizure medications issues relevant to women of childbearing age, and considering referral to an epilepsy center if needed. So at Mott, we also have a big team. This is our village. So we have a bunch of epileptologists, we have an excellent neurosurgeon, our epilepsy nurse practitioners, which a lot of our patients interface with a lot, our nurses who often answer the phones, or don't answer directly, but talk to our families after our clerks answer the phones. We have a bunch of folks in administration and scheduling. We have ketogenic dietitians, a pharmacy tech that helps with prior authorizations, our clinical research team, our social worker focused on epilepsy, and we have the most amazing EEG technologists, Rob's sitting back there, in the planet, in my opinion. So they do a great job with the children. So thank you so much. There's more resources on epilepsy.com to kind of talk about quality care. I think that's it.
Thank you very much for giving us so much new and interesting and helpful information about care across the continuum. Everybody, please join me again in thanking Dr. Dang and Dr. Harris. Good morning. I know I just came in and assaulted you with my voice out of nowhere, but my name is Nadia Van, and I'm a board member on the Epilepsy Foundation of Michigan, and it is my pleasure to be able to facilitate our Q&A this morning. I want to thank our doctors for being brief. You're going to give us a little bit of extra time for questions today. If you would like to ask a question, now's your chance. You can raise your hand, and one of our support staff will be around to come and give you the microphone to ask. We only have 2 caveats about asking questions. Number 1, these are doctors. They have a lot of medical advice, but please don't ask them anything specific. They're going to give us more broad and general answers. And number 2, if you can keep your questions brief so that we can get as many asked as possible. All right, our first question.
Hi, my name is Jackie Carnes. And thank you so much for being here. I appreciate it so much. I'll try and make this quick. I do have quite a few questions. My connection to epilepsy, I am my mother's caregiver. She has had epilepsy since she was a teenager, and her epilepsy stems from a brain tumor that was removed when she was a teenager, which formed scar tissue, and according to her neurologist, that scar tissue has now created epilepsy. She is on multiple medications. She's on 3 medications to prevent grand mal seizures, but she still has, they don't call them petite mals anymore, but absent seizures, whatever you want to call them, every day, multiple times a day. So my question is, she's now 60. She's had epilepsy now for decades. How do I know what decision to make, whether to keep her on meds or to look into surgery?
I'll take that one as the adult epileptologist. So broadening it out, can everyone hear me? Broadening that out to make it less specific. I think anyone who is continuing to have frequent disabling seizures should be considered for epilepsy surgery. And so if somebody's having daily disabling seizures, I think that's an important question to talk to an epileptologist about. When somebody's already had a surgery, that can make any potential further surgery more difficult, but it doesn't make it impossible, and particularly if somebody had a specific lesion that was taken out, which was an epileptogenic lesion, you can develop new epileptogenic sites around that lesion, and so we can do testing to figure out where around the lesion that seizure is coming from, and maybe perform a second small surgery if safe. And of course, this all depends on where it is and where the seizure is coming from, and whether there's eloquent cortex around there, and if we can identify it with some degree of certainty. And then there may be other things in addition to surgery that could be helpful, like we talked about devices or these sorts of things, or more invasive surgeries, whether it's not an open surgery, maybe something like a laser ablation. So I think in those situations, very important to seek care from an epileptologist and discuss that.
Really quickly, follow-up question. So my mom does see an epileptologist. She sees Dr. David Burdett at Spectrum Health in Grand Rapids. He's unsure.
And
Because of scar tissue, any surgery, you're going to have scar tissue.
yeah, so without going into again to the specifics of that particular case, that's true. Any case can be difficult, and particularly when there's already been surgery, that makes things more difficult to make a decision. And understanding how disabling the seizures are to the individual and what the risks and benefits are of a surgery, that's an important sort of seesaw of factors that you have to weigh with your epileptologist. And sometimes the answer is surgery is not appropriate.
Thank you.
All right, we have some other hands raised. We can go to you. I see you with a mic right there.
Yeah, my question's quick and dirty. Have the evaluation tools for surgery changed much over the last 15 years? And if so, is it appropriate to get another evaluation?
Yeah. So I would say yes, absolutely. The tools are changing all the time, and this involves both. There are many ways in which it's changing. Some of the ones that have changed just in my career are how we do invasive monitoring. So when I started my fellowship, basically we were doing almost completely open craniotomy, grid and strip evaluations for intracranial monitoring, and that essentially completely flipped to stereo EEG monitoring, which is a more minimally invasive or less invasive type of intracranial EEG monitoring, less morbid, and a lot of that was due to improvements in technology like the robotic arms that we can program in 3D space now to help guide the delivery of those electrodes into the brain. So that's one way. Other ways are imaging modalities have improved significantly over the last 15 years, for example. And so I commonly talk with my patients about, you had an image done 10, 12 years ago, it might be time to do a new one because we can do a higher resolution image, and even if we didn't see anything before, we might pick up on a subtle finding. And then the other way that I would say it's changing a lot rapidly is in genetic testing and genetic understanding of epilepsy. So not just for what we now consider the genetic generalized epilepsies, but even in focal epilepsies as well. And every year, multiple new genes are added to these epilepsy gene panels, and that can be life-changing for an individual who didn't previously have a diagnosis. Yeah, you're welcome.
Right here.
Question I have is, okay, I've been seeing a neurologist. Neurology, epileptologist. Can you give me a definition of the epileptologist, please?
I mean, I think just from the certification standpoint, there's board certification for epilepsy. So if you can actually look that up too. You go to the AB.
Who is higher, the neurologist or the epileptologist?
So an epileptologist has to be board certified in neurology already, and then it's a subspecialty certification in epilepsy or clinical neurophysiology. So in our opinion, the epilepsy is higher than just a general neurologist.
Okay,
We're all equal. We're all equal.
We're all people.
Okay,
we're all
thank you.
people.
Sounds like there's going to be a cage match outside later.
No one come
I
for
have
us.
a
Don't DM
question
me.
over here.
Okay, so there's two questions for you. First one was, if you didn't get applied to U of M, what was your second choice of job?
Go green.
I had no backup plan. It was only University of Michigan.
I was going to be a DJ. That was my backup plan.
And the second one was, how long do you think you would last on Survivor?
Oh,
Not very long, no. I do not have a skill set that would help me in Survivor.
2 seconds flat.
Hi, I have a question about VNS. I'm a school nurse and I have a student that has a VNS and it is frequently used and it seems to interrupt. At what point will you think that maybe another treatment should be looked into if they're using it? I mean, it is interrupting it, but it kind of reoccurs, and there's sometimes where there's multiple swipes within an hour.
Got you.
I can answer that. The VNS is a vagal nerve stimulator, and it not only gives intermittent stimulation just at baseline, but you're saying we can also activate it by swiping a magnet over it, and then it'll give a higher current of stimulation immediately and for a little bit longer period of time. I think in general, any patient that's continuing to have seizures, there needs to be a discussion at each visit and even in between visits of what to do to optimize medication treatment and non-medication treatment, meaning there's other modalities like ketogenic diet. If this is a patient that could be an epilepsy surgery candidate, then that's something we would consider as well. So we would still consider all the other things. And then with the VNS, there's also things that we can do to modulate the timing of the pulses or the amplitude, the strength of the pulses that we could do as well. So yeah, I think anybody that's still having seizures despite therapies that still seem to be working but not working completely optimally, we have to think about other things.
Thank you.
And I'll add a little bit to that. I run the neuromodulation clinic on the adult side, and some people think that, all right, if somebody's had VNS, that's already a neuromodulation device, maybe another neuromodulation device would not be helpful. But for both of these devices, it's been shown that they work seemingly in an independent way. So people who have had VNS and it hasn't been adequate treatment for them can still get a DBS or an RNS device sometimes, and that can be additionally helpful for treating their seizures. So definitely something to consider.
I have a question in the back.
Yes, all the talk has been centered around pediatrics. I have a 19-year-old. Do MOTS consider taking 19-year-olds?
It's usually institution specific. We draw our cutoff at 21 years old for pediatrics at University of Michigan, but it varies a lot from place to place.
My question is I guess, the adult doctor. What is an acceptable amount of seizures that you should have like per year if you're on the correct medication. My situation, I'm a caregiver, and about every couple months, maybe like 5 to 8 grand mal seizures in a 12-hour period. And I don't know if that's acceptable or if it's like absolutely not, this is crazy. And we have gone to a comprehensive center.
I think, it's hard to say in an individual circumstance because, in my opinion, of course, no seizure is acceptable. However, that saying that, it glosses over an entire conversation that you have with your provider or your epileptologist about what are your goals of care and what are what is your risk tolerance. And so, particularly if you're having grand mal seizures, we know that even 1 grand mal seizure per year increases your risk of things like SUDEP or sudden unexpected death in epilepsy. And if you're having 3 or more per year, that risk increases by 15-fold over people with epilepsy who don't have grand mal seizures. And so, when I have patients who are still having these big seizure types, we want to keep working with them to mitigate that as much as possible, and that can be with trying new medication trials. And there is evidence that even trying new medications in people with refractory epilepsy can be helpful for preventing morbidity and mortality and improving their quality of life, or looking at other options for treating those. So I think continuing to work to try and get those under better control is a worthwhile endeavor.
Yes.
Question. I'm an epilepsy sufferer. I suffer from severe grand mal seizures myself. Negative MRI. I've been epileptic for like 4 or 5 years. I have taken a surface EEG with Henry Ford Center. They tried to, they tried to cause me to have a seizure anyway, or keep me up for a few days. They were unsuccessful with the seizure, but the doctor, when I asked him, I said, even though I've been in here for 2 days, monitored with these EEGs, can you see the epilepsy without me having a seizure? And his answer was, yes, I can. My question to you is, if you were to read my EEG, am I saying that? Anyway, EEG. When you looked at my EEG, if I didn't have a seizure, would that EEG suggest to you what pharmaceuticals I should be attempting to cure or to treat my epilepsy with? Or would you want to look at more data than that?
So that's an excellent question. So the question is does the type of epilepsy based on interictal findings lead you to a specific type of treatment? And so that's what we call the EEG in between seizures, is the interictal period. And there can be abnormalities there that tell us what type of epilepsy you have, whether it's focal or generalized. And there are certain medications we might avoid in a generalized epilepsy because they tend to make things worse. But there's not really a signature or a hallmark that says this medication's gonna be the best for you just based on an EEG. Sometimes if somebody has a lot of EEG abnormalities, we can do a trial of a medication in the hospital and see how those abnormalities react to that. But even that's not a good predictor of whether somebody's going to be seizure-free on that medication. Probably the best hope for this is in the world of genes and genomics, where we're learning more about people's genetic predisposition to epilepsy, and maybe the hope is that that will at one day inform our treatment decisions. I think this question is probably born out of a lot of people with epilepsy's frustration that they kind of feel like guinea pigs when they're in the epileptologist's office. Like, oh, they're trying this on me, and then they're trying this on me, and they're seeing if it works. And unfortunately, that is kind of how the practice is. And we do have rationale behind why we choose the medications we choose, but it can feel that way sometimes. That, I just feel like I'm a guinea pig. But it is important to try medications, see if they work, make sure you tolerate them, and that can be a laborious process, honing in on the correct cocktail of medications, single or multiple, that are going to treat your epilepsy.
We've got time for one more question before our break.
Can I ask one more, please? It'll be brief.
Go ahead.
It seems medically accepted that some dogs can sense seizures before they occur. Can you share with me, if you have any knowledge, the mechanism of operation? How is that done, if you can tell me?
So I can't speak with a lot of scientific clarity on this, but my suspicion is dogs have been bred over thousands of years to be highly attuned to our behavior. And there are things that change in our behavior, and we can see this sometimes on EEGs, that change in our behavior even before an EEG. And I think dogs that are particularly attuned to their owners can really pick that up better than we can, or better than even other humans can.
And then our last question in the back.
Hi, I've had epilepsy since I was 35. Since I was 7, and now I'm 35. And I was because I never really knew how I got epilepsy. I was wondering, is it hereditary or?
Sure, I'll take that one. So there are some epilepsies that are inherited, meaning it can run in families. There are also epilepsies that are genetic that don't necessarily run in the family, but they're still from your genes, and sometimes that can be from a new variant. So I think, the guidelines are basically, if you don't have a defined cause for your epilepsy, then genetic testing is warranted. So that's the current guidelines that just actually came out in the past month. If you don't really know what your epilepsy is coming from, and you've had it especially from like a young age of 7, then it would probably be worth talking to your doctor. Hey, is this something that we should look into, and should I get any genetic testing for that?
All right, I want to thank you all, pardon me, for your excellent questions and for your excellent participation during this part of the session. I'd also like to thank Dr. Harris and Dr. Dang for being here with us today and providing this excellent information. If we could give them one more round of applause.